textbooks, dermatology, primary care. Throughout our lives, we will all interact with the healthcare system. So, what happens when that system is not designed with certain groups of people in mind? As a Black person in America, I have experienced firsthand racial disparities in healthcare. The turning point for me came during the pandemic when at a local clinic, I was asked if I had a red rash on my skin. At that point, it dawned on me that some healthcare professionals did not realize that skin rashes do not exhibit the same way on different skin pigmentations. If something so obvious could be so casually overlooked by a healthcare professional, what other elements of care, treatment, research, and education are also being ignored, and what does it mean for people of color using this healthcare system? I am Vivian Kobusingye Birchall, and in this series, we will take a closer look at racial disparities in healthcare, speaking with medical professionals, and hearing personal stories to get a better understanding of those disparities and explore ideas and strategies for how to bridge the gaps. Welcome to Healthcare Disparities. I'm Vivian Kobusingye Birchall, your host, and my guest is Dr. Conn, who is going to be talking about interventional pain medicine and the disparities therein. So, Dr. Conn, welcome to the show.
Thank you for having me. Good to see you again, Viv.
Good to see you too. So, what is interventional pain medicine? Let's start there.
Right. So I do interventional pain medicine, and I primarily use procedures on the spine and other nerves in the body to decrease pain. I also do headache medicine in addition to that. And I do use some medications along with my interventional treatments. And I minimize the use of opioids in the care that I deliver. That's
Excellent. So what does interventional pain medicine mean for a person who is not a medical doctor or in healthcare?
So I do nerve blocks on the spine, or some of the more simple things that I do. The nerves coming off the spine and the joints of the spine itself. That's what I spend most of my time doing. I also do small fracture repairs, and I do pacemakers for the spinal cord when people have very difficult pain problems.
Are there any significant trends of the demographic of patients that you see?
Right. In general, I do see older patients because they've had more orthopedic problems. People develop arthritis and thickening of ligaments and disc injuries over the years just from living, because the discs dry out just like the lenses in our eyes dry out and we need glasses. I do see some younger patients because people have trauma. They hurt themselves playing sports or lifting and different things like that. So I have younger patients, and sometimes people develop unusual pain responses that are younger, but the majority of my patients are older.
So are there any significant disparities in access to care in your line of work? And if so, what are those disparities? Let's begin with the racial disparities.
Yes, I would call it disparity within disparity because in general, there is not enough interventional pain care or pain care for anybody. Okay, and the patients are discriminated against often across the board. Okay, so that's the first disparity. And then the disparity within the disparity is the difficulty of different ethnic groups in our world in America that experience, prejudice. And so that's the disparity within the disparity. That's the way I would initially introduce the topic.
Right. And why do you think these disparities exist? What are some of how would I call them? The roadblocks to access to care?
Okay, so I'm going to answer the question in parallel to the way I answered the first question. I'll give the overarching answer that applies to everybody, and then I will kind of try to zero down to the unique disparities within the field.
Yeah.
I think pain is hard. People still don't understand what's available, like interventional care and other medicines other than opioids. And people are afraid to go to care for pain in general because of the opioid crisis.
We'll get into that because that's another
Yes.
elephant in itself.
Right, it's another elephant, and it affects everybody, even though myself, I'm not a big opioid prescriber. People are afraid to come to a pain doctor because of the opioid crisis. We spend a lot of time educating the patients. My office staff talks on the phone to patients. They reassure them, like, we're not a pill mill or any of that kind of thing. We even have to do that, like when they're making their initial appointment. So people feel discriminated against just because they have pain. I think all people feel that. Well, a lot of people can potentially feel that. I'm not saying every single person feels that. And they're sometimes afraid to come to care in general because of those different factors. And people are afraid they're not going to be listened to because pain is subjective. Like, it's not a broken bone. Well, I can actually see things on the images, and I can tell people have severe problems with their spine, but it's not something that can be seen at first glance without imaging. It's not like a bone is crooked or somebody has a rash or a cough or a fever. Those signs are not present. So it requires that we listen to people and listen to their experience and what they say. And I think most of us are afraid we won't be listened to. And I can understand that.
There is it's like a stereotype out there that Black people don't feel so much pain.
Right.
Is that something you've encountered in your practice, and is that bias prevalent in your,
Yeah.
throughout your field?
Yes. And now we're drilling down to the next layer of the question, and you're absolutely right. When I was, thinking and reflecting about this interview today, it brought back memories in medical school that I heard said that Black people have thicker skin and have a higher pain tolerance, which is foolishness. That's absolutely not true. Okay. And when I was reading some articles in preparation, apparently in medical schools, even today, some of this stuff is talked about, which is outrageous. So we need to be making sure that medical education is done appropriately using scientific facts, because those are falsehoods. Those are false beliefs that don't need to be perpetrated. And yes, that's out there, and it is untrue.
That is very scary, because if you mentioned that it's something that happened in medical school, you would think that medical school is based on science and facts. So how can we remedy that? How can we fix that?
Yeah, the educational system. I mean, things have gotten better. I think what discouraged me today when I was reading, I went to medical school in the 90s, and some things have gotten better since then. But the articles that I was reviewing today, I haven't been in medical school in a while, but it mentioned that medical students are still exposed. These questions come up. Okay. And so, in a way, thank goodness people will ask the question, because when they ask the question is when we have the opportunity to educate. We need to both preemptively offer facts and also allow people to be in a safe environment where they can ask questions and say, I've heard this, is this true? So that a really nice, safe exchange of information can occur, where people can remodel their beliefs, take in new information.
In your experience, are there enough providers that maybe would understand what the pain that African Americans or Black people would go through? And if not, why?
Yeah, this is a really interesting question. And in my specialty, I don't know the racial breakdown, but I can tell you it is highly male dominated. There are not enough women in the field. I believe the last statistics I saw, that in interventional pain in particular, it's like 85% men.
Wow.
We love men, there's nothing wrong with men, but it just doesn't reflect medical school admissions, which are now greater, women than men. And so that's an interesting thing. In our national group, we actually have just developed Women in Interventional Pain Management, and I'm personally mentoring some women through. So yes, and I'm happy to do that. Now, as for the ethnic breakdown, I don't really know those numbers. So I can't provide a good answer for that question.
That's okay.
Yeah.
Yeah, first of all, there's one recurring theme that I've heard from people talking about these disparities. I spoke to a doctor, he's a clinical researcher in radiation oncology, and he was also talking about there not being many physicians or doctors or clinical researchers in that area that are Black. So, and I'm also hearing the same trend here. But also the other interesting thing is, you mentioned the percentage of women who are now enrolled in medical school. That is very empowering.
I would say there's a few ways I'd like to talk about how we know there's a problem. Give a little bit of evidence about how we know there's a problem. There's a really well-known study in Annals of Emergency Medicine by a Dr. Todd, showing that when people come into the emergency room with fractures of extremities, so that's acute pain, which, I told you I do treat acute and chronic. Acute means rapid onset, there's a new injury. Chronic means there for a long time. So, but to circle back now, when people come into the ER, that 74% of white people were given opioid medicines for the fractures, and 57% of African Americans were. So that's a significant that's a disparity, and that's well known. So I know I'm not an emergency medicine doctor, but I know that a lot of education has happened about this, and I hope it's improving. And perhaps you could interview an ER doctor that could speak more specifically to some of the changes. Now, to move on, I wanted to talk about how we are aware of disparities in chronic pain. There was a very large study done at the VA, involved 15,000 people. Okay, what was found in this study is that African Americans, when they had a problem, their urine drug screen, because we do check people's urine drug screens, their medicines were taken away more quickly. Okay, and they were tested more often for the urine drug screen. So that's a very large study that shows, that this is there. But I will give another side to this. Also, there are several studies that show that African American people receive less opioids for non-cancer pain. And now that's really interesting, because the reality is, no matter what the intention was for that, it may have turned out good. Because there's not one study supporting the use of opioids for non-cancer pain, and hence the opioid crisis. So the historical fact that occurred, for whatever motivated that to occur, it may not have been so bad, that particular thing. So we have unintended consequences that turn out beneficial for patients and not beneficial for patients that occur in medicine. And so I just wanted to point that out.
I mean, that is so interesting. First of all, what is the danger of the first part that you talked about, where they are screened more and given less of the medication? The more urine screening. Yeah.
Right. Okay, so when people are given opioids, we have to monitor their urine drug screens. So we're testing for whatever we give them in the urine. And we're doing this to make sure, first of all, they're taking the medicine and they're not taking another opioid. So why does it have to be in there? Because there's something called diversion. People give their pills to family members or sell them. We don't want people to divert their medicine, because it's illegal. It's not good to take other people's medicines, And we also are checking to make sure that substances of abuse are not in there, or they're not getting drugs they shouldn't be getting from somebody else. So that's the reason for the urine drug screen. We're checking for compliance and safety. Okay.
Yep.
Yeah.
So what is?
And so urine drug.
Is there any danger in focusing on more screening on the Black or people of color?
Well, I mean, I see it as prejudicial because rules should be applied equally to everyone. We don't need to be signaling people out um,
Right.
due to their race. I
Right.
mean, sometimes if I think somebody is abusing, I will test them more, and I believe that I'm doing that based on their behavior, not based on the way they look.
Right.
Yeah, so
Well,
it's, but this involved 15,000 people, so the data is pretty convincing because it's a large group of patients that they studied through the VA for this.
that is very good to hear that you're very sensitive to prejudice or prejudicial practices or potential prejudicial practices. Sorry, but
Right.
yes, I guess the reason we wanted to, the reason this show was created was to identify some of these disparities, and not only just identify them, but try to find brainstorm ways of addressing them. So, is there something that we haven't mentioned that you would like to tell our viewers about disparities in general? It could be about causes or how to address them, at least in your line of work.
Yeah, I think, right, pain management in particular is uniquely vulnerable to disparities and then the disparity within the disparity, like I started with. We need better science, okay? We need better science and to help us measure pain. I think one day we're going to be able to measure pain in ways we haven't thought of yet, and that will level the playing ground. And some of the great minds are thinking about this, thank goodness, but it's a ways away. So we need to rely on education. Education in medical school and in general, pain is not well taught in the medical schools. And then we also need to rely on education in our professional society.
Before I let you leave, there's one thing that you mentioned at the very start. One of the pains that you manage are headaches.
Yes.
That is a very common pain that people have. What are the trends that you have seen in terms of headache management, and what would you advise?
Right. I am board certified in headache medicine. It's a fascinating field. It's really been revolutionized in the last 3 years, and we can help people we've never been able to help before because we have a whole new class of drugs that act on something called CGRP. So that's very exciting to help the patients in new ways. And I've been with people for years, and now I've been able to help them in a way that I couldn't before. So I find that very gratifying. I will say, on the other side of this, headache is uniquely discriminated against. Women suffer more than men for many reasons, mainly hormonal, but there's a bunch of reasons for that. We know this to be a fact. And I still have patients come in that were told, in the 70s and 80s that they were crazy because they had headaches.
Really?
It wasn't true. Like, it's just so denied because you only can listen to what the person says.
Mhm.
And most of my older patients have felt discriminated against about their headaches. They felt like nobody listened. And in fact, I think they were right some of the time. I think we haven't done a good job in headache medicine in educating the other specialties well enough, because I still see patients come in and they feel discounted by their doctors because there are no objective findings. I don't know. I have migraine myself. I believe the patients, you know. So it's very easy for me to believe the patients.
Right.
But it's a very exciting time, and we're helping a lot of people we couldn't help.
Well, doctor, I know you have to go to attend to your patients, but I just wanted to really say thank you for taking us through a type of medicine that is not usually talked about. That is the interventional pain medicine. And probably some other time when we have more time, we could go in depth to, continue
Yes.
pointing out, first of all, to talk about the advances in pain medicine, and also,
Mhm.
some of the things that are being done in your field to bridge these healthcare disparities. So again, thank you for being a guest on our healthcare blind spots, and to our viewers, thank you for watching. Till next time.